Your Excellencies, distinguished guests, speakers, participants, good evening from Dubai, United Arab Emirates. My name is Anas Al-Madani. I am the Vice Chairman and Group CEO of Index Holding. I would like to welcome everyone to the Waterfalls to the Continuing Education Program and would like to inform our participants who are here joining us today that the session will start after the welcome notes. Before I start, I would like to take this opportunity to share a few words on the Waterfalls initiative and its importance. The United Arab Emirates, and since its inception, has been at the forefront of spreading peace, knowledge, and extending its support and friendship to countries all over the world under one message to humanity that we are all one. This is what we have learned from our founding father, the late Sheikh Zayed bin Sultan Al Nahyan, God bless his soul, and this legacy is being carried through with the wise leadership of the United Arab Emirates and the citizens of this great nation. The Waterfalls Continuing Education Program Initiative was launched by His Highness Sheikh Mohammed bin Rashid Al Maktoum, Vice President, Prime Minister and ruler of Dubai, under the guidance of His Highness Lieutenant General Sheikh Saif bin Zayed Al Nahyan, Deputy Prime Minister and Minister of Interior, and under the supervision of Ministry of Possibilities in collaboration with Index Holding. This unique initiative aims to train health and medical professionals all over the world through an educational program that includes lectures and workshops in various fields. This initiative so far has witnessed participation of more than 230 doctors and specialists and has attracted so far 76,000 participants from 181 countries. And today we are grateful to welcome the Kiroslat Group to be part of this initiative. The Kiroslat Group is a leading group in Spain and Europe with over 60 years of experience caring for people and well-being. They're supporting this program with the participation of 40 speakers in various health fields. Distinguished guests and colleagues, it gives me great honor to welcome on your behalf the man who is behind this initiative with his vision, with his leadership and support to make Waterfalls Continuing Education Program a reality. It is my pleasure to welcome His Highness Sheikh Saif bin Zayed Al Nahyan, Deputy Prime Minister and Minister of Interior, to say a few words on this occasion. Your Highness.
Assalamu alaikum, jazakum Allah bil khair. Hello everybody. Thank you very much for sharing with us at this part of the world, in the Middle East. And you make the world is smaller as one house from this gathering and helping the people and helping the world and sending this positive message through your good job. So I would like to appreciate Dr. Abdullah Madani that he came out with this idea. It's not my idea, it's his idea. So I appreciate this. And also I would like to thank everybody who's with us tonight. I believe there is 300 or plus more doctors who will share their knowledge to their colleagues. But for sure, you will share the positivity of humanity. And also I would like to thank Dr. Anas Madani I'd like to thank also Professor Mario, Professor Abdullah رواح, وسعادة ماجد فلاسي, وكارلوس سيغو, والدكتور رومون, and of course all the rest. This part of the world is, it used to be very far from your country in Spain, but now through this challenge, we are closer. We have to change this challenge to opportunity, and this is what you showed us today. Thank you for your organization. Thank you for your humanity, and I hope all the success for you and for all over the world. شكرا عبد الرحمن بعد. Thank you عبد الرحمن.
Thank you very much.
Please.
تفضل طويل العمر.
I hope you good luck, and I will try inshallah to work through you to bring more opportunity. And if there is anything that we can work together to help the people, not only in COVID, we are, I think, in a certain level. So we think we should look at other challenges that we could do something. Once again, thank you very much. شكرا للجميع. تحياتي.
شكرا طويل العمر. Thank you, Your Highness, for your kind words of support. Thank you for supporting this noble initiative. Your leadership and guidance, with your leadership and guidance, we are confident that we'll be able to reach the goal of this initiative, the Waterfalls initiative. With your leadership as well, Your Highness, we are confident that we can, together in many parts of the world, work together to solve many problems of the humanity, to support each other, and to continue the legacy of the late His Highness Sheikh Zayed bin Sultan, God bless his soul. With your permission, Your Highness, I would like to introduce our guests and start the program. First of all, I would like to introduce Dr. Mario Cramenati, Director of Scientific Committee, Head of Cardiology at San Donato Hospital, Milan, Italy, a Scientific Director of Coral Center. Dr. Mario, the mic is yours for a few words on this occasion.
Thank you very much, Anas. It's a great pleasure for me to take part of this outstanding initiative. As presented by Anas, I'll be the scientific director of the Coral Initiative for Pediatric Cardiology and Cardiac Surgery. And as you know, the problem of congenital heart defects is spread around the world with different bulky job, because in many countries, the facilities for taking care of children with congenital heart defects are limited. On the other hand, the progress that cardiology, cardiac surgery, intensive care unit made along these years allows us today to take care even with very, very complex heart defects. And of course, it's necessary to have a cooperation between different specialists from newborns to adult age, cardiologists, cardiac surgeon, intensivists working together can deal with very complex heart defects. If you look back at the years of cardiac surgery, well, 30 years ago, the mortality for congenital heart defects was as high as 30%, at least. Nowadays, mortality is lower than 4%. However, we can improve much more what we can do now, particularly in interventional stuff, I'm a pediatric cardiologist, and of course, I'm particularly involved in transcatheter interventions for many congenital heart defects. And we experience around these years the possibility of avoiding surgery in many patients or doing interventional procedures as complementary to cardiac surgery. So the cooperation between cardiologists and surgeons is the key issue to achieve excellent results in dealing congenital heart defects, starting from the simple ones to the most complex. So it's a great honor for me and a great pleasure to try to do my best to lead the cooperation among many international specialists to optimize the program of taking care of caregivers in many countries, organize webinars or workshops to improve the knowledge of the most advanced interventional and surgical strategies for congenital defects all over the world. Try to speed up the improvement that we can achieve in many countries. So it's, again, a great pleasure to take part of this outstanding community, and myself and the other distinguished colleagues are ready to get started to work together hard to get improvement as quick as possible and to achieve the best results that we can. So thank you very much for being here.
Thank you very much, Dr. Mario, for your kind words. Thank you very much as well for being part of this program. Now I'd like to take the mic to Professor Abdullah Raweh, who is actually not a stranger to the UAE. Professor Abdullah Raweh is a consultant and cardiac surgeon from London, UK, and he's an advisor to the Kieran Slode group, and a visiting professor and director of the Lode University in Switzerland, and also a Coral Foundation scientific director. Professor Abdullah himself is very active in many areas, and especially in humanitarian areas. Professor Abdullah, welcome, and we give the mic to you for a few words.
Thank you very much. Thank you, Anas. Thank you, all of you. Mario, thank you to be here with us. Mario did a lot of operation with us here in Dubai for charity. This opportunity is very important. Really, on behalf of myself and my colleagues in London, Spain, Switzerland, in Italy, I would like to take this opportunity to thank His Highness Sheikh Mohammed bin Rashid Al Maktoum and His Highness Sheikh Mohammed bin Zayed Al Nahyan and His Highness Sheikh Saif bin Zayed Al Nahyan for such a great opportunity presented to the frontliners in the world through the Waterfalls Global Initiative from the UAE to the world. This is for the continuing medical education for 1 million medical professionals. So it's honor for me, for my colleagues to participate in this program, that it's unique initiative, that it's the first in its kind in the world to cover all the specialties, all the medical specialties under one roof, deliver CME at their hospitals and and their clinics and their medical college at no cost. I'm sure the initiative will add value for every one of our colleagues in the world, especially during this period that is very hard, very difficult period for all the world, the situation of COVID-19. UAE is doing and did a lot to help the world in this pandemic. And we continue now through this initiative to do very important things, and it's really a great opportunity. Thank you, everyone. Thank you to be with you in this. Thank you.
Thank you very much, Professor Abdullah, for your kind words. From here, I take the mic to Barcelona and to His Excellency Consul General Majid Al-Falasi for a few words. Your Excellency, I leave the mic to you.
شكرا. سيدي سمو الشيخ سيف بن زايد آل نهيان، نائب رئيس مجلس الوزراء وزير الداخلية، مهندس أنس المدني نائب الرئيس والرئيس التنفيذي لشركة اندكس القابضة، الدكتور رامون أروي المدير الطبي لوحدة الصحة الإنجابية بمستشفى تكنون، سيد كارلوس مسؤول تطوير الأعمال بمجموعة كيرون، السيدات والسادة، السلام عليكم ورحمة الله وبركاته. Buenos tardes. إنه لمن دواعي سروري أن أشارك اليوم بتدشين الجلسة الافتتاحية لسلسلة المحاضرات والندوات والورشات التدريبية من خلال مجموعة كيرون الصحية، والتي أطلقها صاحب السمو الشيخ محمد بن راشد آل مكتوم نائب رئيس الدولة رئيس مجلس الوزراء حاكم دبي رعاه الله، وبمتابعة كريمة من سمو الشيخ سيف بن زايد آل نهيان نائب رئيس مجلس الوزراء وزير الداخلية، بهدف تدريب وتمكين نحو 1,000,000 شخص من الكوادر الطبية حول العالم. وتأتي هذه المبادرة التي تعد الأكبر على مستوى العالم بمجال التعليم والتدريب التخصصي، لنؤكد على قيام التضامن والعمل الإنساني التي غرسه الوالد المؤسس الشيخ زايد بن سلطان آل نهيان طيب الله ثراه في الهوية الإماراتية، ولا سيما في هذه الأوقات العصيبة التي يمر بها العالم في مواجهة تداعيات فيروس كورونا المستجد، والذي يتطلب منا جميعاً التضافر والتعاون من خلال هذا النوع من المبادرات. كما أود أتوجه بجزيل الشكر للقائمين على تنفيذ هذا العمل الضخم من وزارة اللا مستحيل وشركة اندكس القابضة في نقلة نوعية في مجال التدريب التخصصي، ولا يفوتني أن أعرب عن خالص الامتنان لمجموعة كيرون الصحية التي رحبت منذ الوهلة الأولى بمقترح القنصلية العامة للمشاركة بالمبادرة المميزة من خلال كوكبة من كبار الأطباء. ونتطلع من خلال سلسلة المحاضرات التي تبدأ اليوم تحقيق أعلى درجة من الإفادة والتطوير. شكرا لكم لحسن الاستماع. Muchas gracias.
شكرا سعادة ماجد الفلاسي على هذه الكلمة. Your Excellency Majid Al-Falasi, thank you very much for your kind words and also for your support to this important initiative. I would really like to thank His Highness Sheikh Saif once again for his contribution, his support, his leadership to this important initiative, guiding us through this important initiative to support our frontliners all over the world. And also, once again, I also like to thank the Kiron Load Group, who has been really actively supporting this initiative since we have been talking with them, and really having 40 of their faculty and scholars sharing their knowledge with their colleagues all over the world. On that regard, I would like to hand over the mic to Mr. Carlos, the Regional Business Development Director at the Kiron Group. Mr. Carlos will be moderating the session with Dr. Ramon. The mic is yours, Mr. Carlos.
Thank you very much. Mr. Anas Al-Madani, Vice Chairman and CEO of Index Holding, Excellency Majid Al-Falasi, General Consul of the UAE in Barcelona, doctors, to all present. On behalf of myself and Kiron Salud, I would like to take this opportunity to thank His Highness Sheikh Mohammed bin Rashid Al Maktoum, His Highness Sheikh Mohammed bin Zayed Al Nahyan, and His Highness Sheikh Zayed bin Zayed Al Nahyan for such a great opportunity presented to the frontliners in the world through the Waterfalls Global Initiative from the UAE to the world and for the continuing medical education for 1 million doctors in the world. As you know, our company is the largest hospital group in Spain. Kiron Salud Healthcare Network comprises over 100 hospitals, institutes, and other medical facilities. We also have international presence. In the Emirates, in Dubai, we manage the Kiron Salud Medical Institute, dedicated to specialties as ophthalmology, traumatology, and fertility. Likewise, we manage hospitals in Portugal, Colombia, and Peru. Currently, Kiron Salud is developing multiple research projects, and many of our centers are performing cutting-edge work in this area, making them pioneers in different specialties such as traumatology, ophthalmology, oncology, cardiology, fertility, and neurology. Likewise, the group works to promote teaching. 8 of our hospitals are universities. In the field of promoting teaching, medical and scientific research, we are aware of the possibilities to strengthen the great relationship that we have with the UAE through the Waterfalls project. Last month, we had the pleasure to celebrate a meeting with Excellency Mr. Al-Falasi in Barcelona, and through that visit, we considered to make the most for our institutions in terms of collaboration amongst Kiron Salud Barcelona doctors, a large team of highly specialized and world-renowned professionals and institutions of the UAE. And today, we are glad and honored to start the collaboration with the first masterclass offered by Dr. Ramon Aurell, Medical Director of the Fertility Unit in the Kiron Salud Campus in Barcelona. Thank you very much.
Thank you, Mr. Carlos. And Dr. Ramon, the mic is yours now for the first session. Dr. Ramon is the Medical Director of the Assisted Reproduction Unit at the Hospital Kiron Salud, Barcelona. Thank you very much, Dr. Ramon, for your contribution.
Thank you very much. Good evening, doctors. 3 quick instructions for the doctors. The questions to Dr. Aurell can be typed in the questions and answer box in the platform. Some questions will be answered by the doctor at the end of the session, and the certificate of attendance can be collected at the end of the session. It's a pleasure for me to introduce you Dr. Ramon Aurel. He's the Medical Director of the Fertility Units in the Tecnon Medical Center and the Kiron Salud Barcelona Hospital. He has participated in several projects, conferences, and sessions, in addition to being published in prestigious national and international journals and books. With his dynamism, effectiveness, sensitivity, and striving to offer the best to couples, he aims to create a leading unit on both the domestic and international stages. He is an international speaker and has been lecturing and visiting IVF clinics all over the world. Please, Dr. Ramon Aurel, you can make the presentation, please.
Thank you.
Thank you very much.
Thank you very much. Well, first of all, I have to thank you, Waterfalls, for this magnificent opportunity to basically opening this lecturing. I didn't know it was going to be a sort of worldwide opportunity, so I'm really glad to be the one opening this journey that I'm sure is going to be very faithful for you from the other side of the world and for us here in Kiron Salud. As a medical director of the IVF setup here in Quirón Salud, Barcelona, when Carlos was asking me what can I offer to the audience, I presume majority will be gynecologists or trained in IVF, is basically what has changed in the 21st century on the fertility approach to the patients, and of course, as a modern approach. You all know very well that over 35 years ago was the first baby through IVF was born in the UK, and after that, in 35 years, we passed from having a 10% pregnancy rates per cycle to cumulative pregnancy rates today of nearly 90%. So really, we made it really, really big, and the changes we have in the last 10 years, I hope I'm going to summarize that in the next 20 or 25 minutes. As Carlos introduced to you, we have 4 general hospitals in the area in Barcelona with 2 big consultation areas and 2 IVF laboratories with continuous education, efficiency, and continuous improvement. And if you look at our activity in the last 10 years, we did nearly 10 cycles of reproductive medicine between IVF, insemination, fertility preservation, and of course, on the egg donation program. I really like this slide because today when a patient comes to the clinic, normally the first thing they ask you is, what are my chances of getting pregnant once, I have the treatment with you? I keep telling them that if you are sort of a good prognostic patient, that you are, less than 35, that we have more than 10 expert stimulation cycle, and we manage to get you more 4 or 5 blastocysts, your chances of pregnancy will be, as you can see on the screen, well over 90%. And I think that tells you through the lecture I'm going to give you, how can you achieve that if you really select with your patients and you have the best technology that we have available. But let's go to the point of the major changes. I thought a lot of those are very embryological, but they change a lot on our IVF working in the last 10 years. Vitrification, as you know, is a new sort of freezing technology. The pre-implantation genetic test that will go there in 2 or 3 slides for you to understand when we have to do it, and the results that we have. The freeze-all strategy, that how in the last sort of 10 years, we don't have risk of hyperstimulations anymore with these new freeze-all strategies. Then the protocols. When I went to the Emirates in February before the COVID, and all my talks all over the world, how we have changed the way we stimulate the patients, the protocols we use, and the dosage to give, the best results at the end of the day. And again, what is in technology, the best thing we have nowadays is the continuous embryo monitoring through the culture systems and the time lapse that we have in our labs here in Barcelona. If you look at this slide on the left-hand side, you can see that more than 50% of the transfers are not done on a fresh cycle anymore. So that's because vitrification gives us the opportunity to have nearly same results or best results with frozen embryo than on a fresh embryo. So we are now passing from freezing only about 9% of the cases to freeze more than 35% of our IVF cycles. And why is good vitrification? Of course, vitrification gives you the possibility of the biopsy embryos on day 5. And again, if you look at the red colors at the end and the results of the slow freezing through the vitrification, you can see vitrification has really given you, I'm trying to see if I can point you here. No. If you look at the 2018 vitrification slide, the pregnancy rates are nearly double on what we have with the slow freezing technology. That's why vitrification is very good. And why is good vitrification? Indeed, these 3 things that I'm marking here. Of course, in the pre-implantation genetic test, in the frozen embryo replacement treatments, and of course, in the vitrification of oocytes for oncology cases or social freezing in younger population. What about the PGTA on day 5, the pre-implantation genetic test? Again, in the next sort of 5 to 10 years, we increased 30% the number of patients that had PGTA, normally because the patients we have here are over 38. I don't know in your population in the Emirates, but now in our clinics, 80% of our patients are over 38. So really, we have to offer them the best chance having a normal euploid embryo and having then more success rates. But again, PGTA on day 5 is not only better pregnancy rates. Of course, you will decrease little embryos. You transfer one at a time. So you're increasing the pregnancy rates well over 12%, from a 48.2% to 60%. And again, what's more important in Europe, decreasing multiple rates by 15%, coming down to 5%. Remember, 10 years ago, before freezing, before vitrification and slow free and stimulation with PGTA, we, with Greece and Italy, have a 25% pregnancy rates. That's going down dramatically thanks to the pre-implantation genetic test. And again, I always say to the patients, the PGTA is not going to change the embryo. The embryo is what you have with your egg and your sperm, but the guarantee of transferring a healthy embryo increases the chance of a pregnancy over 60 or 65%. And again, in recent papers, I'm sure you've seen that probably in the next year or 2 years, we'll have the non-invasive aneuploidy testing. We don't have to laser the embryos anymore, and we can see the euploidy or aneuploidy of these embryos in the culture media. There's a lot of studies running at the moment with, of course, the both techniques to make sure that it's going to be safe and effective in the near future. If we go to the freeze-all strategy, as I told you, we are freezing now 16 or 20% more than we did 5 years ago, back in 2014. Why is that? As I said before, with the freeze-all strategy, we're going to avoid the hyperstimulation risks that I'm showing your country. You have a lot of young population with PCO, ovary, and the risk of the concerns of hyperstimulating is very high. So with this technology, you will avoid this. We have less risk, more efficiency, and more efficacy. Remember, in Spain, we're doing 70% of the egg donations from the European countries, from France, from Italy, from Germany, from England. Now with the COVID, of course, we have to manage to make the blastocyst travel, but that's a problem for all the countries in the world. But again, we are experts in this freeze-all strategy and, of course, of avoiding the hyperstimulation for the egg donation young girls. The endometrium preparation is much better. You don't have to concern as much as the progesterone. Of course, we now measure progesterone before the embryo transfer, but we're not as concerned with the fresh embryo transfer as we were before. And again, it's beneficial, of course, not for everybody, but definitely for more than 15 oocytes when you have a risk clear of hyperstimulation, stimulating the patient. And if you look, our first attempt after freeze-all, the pregnancy rates are much, much higher and over 60% of the cases. But probably in the audience, I presume majority of you doctors, colleagues are gynecologists, and you're more concerned on the stimulation. And I'm sure you agree that we've moved completely from to individualized and personalized stimulation protocols. We move from agonists to antagonists. We don't do agonist cycles anymore for the risk of hyperstimulations. We increase the use of the LH at back, the medication that helps, especially in aging population patients or in a low ovarian reserve. Recombinant FSH alone or combination with recombinant LH to maximize the quantity and the quality of the oocytes. I don't know in your country, in the Emirates, but in Spain, we have 6 major companies now giving different recombinant FSH or LH, urinary HMG, and again, the biosimilars. If you are strict to what's scientifically proven, what is genetically created, so the recombinant FSH-LH should have more purity, more efficacy, and again, if you have more oocyte at the end of the stimulation, better pregnancy rates. We managed to synchronize the follicular stimulation with the OCP, the estradiol priming before the stimulation. That's a way of doing that. And again, with the final trigger on the follicular maturation with the agonist instead of the HCG in the cases that you're clear that you're not having an hypo patient or severe PCO patient, will avoid the hyperstimulation syndrome. We move from the mild to mini stimulation that we had in the Northern European countries 10 years ago to the super stimulation. We now know very well that if you have more oocytes, 15, 20, 25, you will get more embryos, and of course more euploids, and again, a better success pregnancy rates. Again, we move from the multiple pregnancy to triple or double to a single embryo transfer, and improve the embryo transfer techniques with the scan and all these very echo-guided embryo transfer guides that you can see with the catheter very well where you put the embryo. We move from the intramuscular, painful progesterone to the vaginal dose or route that it's easy, of course, for the patient, self-administered and little side effects. And again, we're all looking for safety, efficacy, and efficiency. That's what I think we have to give to all our patients. How do we move to individualization and personalized stimulation of protocols? I mean, I think you all have, again, in your country the same as we do here in Europe, the 3 top biomarkers to predict ovarian response. The age is very important. You can do whatever you want. You can have whatever you do. But over 38, 40 years of age, again, the chances are much less. Anti-Mullerian hormone is important, but remember, always has to go together with the antral follicular count. You cannot believe an anti-Mullerian hormone is going to give you the clue, because if you've seen in different papers, you can have a same lady having anti-Mullerian in 3 different labs, and this poor lady having a higher AMH, normal AMH, or lower AMH. So really, you have to see on the scan how many follicles you have in both the ovaries, and again, to predict the ovarian response. And again, you have to find the best protocol for each patient's profile. You have to be able to predict the ovarian reserve. You have to be able to choose the right protocol to start the right dose, because remember, the dose you start on day 1 is the one that's going to follow the follicular growing of the follicles. We used to start at the beginning doing this increased dose or lowering the dose. No, it's been all proven today that the first dose you give on day 1 is going to recruit the maximum number of follicles, and that's what you're going to get in, of course, the whole stimulation protocol. And again, try to choose the right drug. As I said, in Spain, we have many, many different ones. All the companies are good. You have more or less same results, but again, you have to try to give what you think is best scientifically with Cochrane database and literature setups, what's best for your patient. And I'm sure you will agree with me here. The more oocytes you have, the more embryos you will get. And then remember, on the slide number 3, the better cumulative pregnancy rate you will have. And the important message here is how quick can you get this woman pregnant? Again, with safety, but efficacy will be the time for this woman to have a baby. You all know very well this graphic from Shesh Shunkara, a very good friend of mine when I trained in the UK. Shesh has very clear that if you look at the age ratio, 15 should be or will be the ideal number of eggs. So we must find the right balance. It's okay if you get 20, 25, or 30, but then you have to, for sure, freeze all that cycle to avoid hyperstimulation, severe hyperstimulating this patient. But if you have 15 or less, unless your estradiol level is very high, it's a very thin woman, and you're concerned, then you can go, of course, for an embryo transfer. But always remember that you have to collect what you have in the ovaries, but without compromising, or safety must be your paramount. We all have patients that have between 35 and 55 eggs, but that should be avoided. Because again, the more eggs you have more embryos. Yes, but again, the risk for the patients could be also very important. In this graphic, you'll see very well the way we individualize the treatment, depending on, of course, the anti-Mullerian you have and your follicular count, the dose you will start, again, 150 if it's a normal high responder, 225 if it's normal or on the lower side, and again, over 300 if it's a low responder. Understanding, all of you, that it doesn't matter if you give 300, 400, 500. It's well demonstrated that above 300, it doesn't change at all, and it's going to give you more eggs. So you don't have to risk or to give more medication. It's expensive for the patient. Age is very important. As I said, in Europe, I'm sure you have the same as we do here in Spain. The age of the patient is very important. We have more than 80% of our patients are over 38. And if you look in this graphic, the pregnancy per cycle in these patients won't be more than 20-25%. And I like this New York Times magazine 4 years ago. The patients know, they know very well that they can get pregnant at any age. But for us, responsibility is a must. We, in Spain, we don't have a policy giving you the limit on the age of the woman. But again, 50 should be ideally the age that we use for these patients. I like this graphic very much. It helps us to work on the daily basis. If you look at the women after the age of 38, that's when I think pre-implantation genetic test for the embryo should be employed when you have more than 50% of an aneuploidy. If you tell a patient age 38, 37, 38, 39, that more than 50% of the embryos that you have, they could be type A embryo, beautifully, a blastocyst, but more than 50% of those embryos will be abnormal genetically speaking. If you do the genetic test, you then transfer an aneuploid embryo, and the success rate will go over, so there's 20% if you don't do the test, over 60-65% if you do the PGTA. And Filippo Baldi just led me this slide. I think it's very interesting. If you look, and that's very important for your day-to-day clinic, and I think I'm going to copy-paste that for us. If you have a patient 35 or less, and you want to guarantee an aneuploid blastocyst, remember, 60% rate of aneuploidy, you'll need 5 mature oocytes to get an aneuploid blastocyst on a 35-year-old woman. But what happens if you want to get an aneuploid blastocyst in a 39, 40-year-old woman? Look at the aneuploid rate, 30%. You know in this lady that only from 10 embryos, 3 will be genetically speaking normal. So you need to have at least 9 mature oocytes to have 7 fertilized embryos, and then 3 blastocysts to get 1 aneuploid blastocyst. So really, it's not easy to get there. And again, what's more concern for us, if you have ladies from over 42, 43 that you have to convince how difficult it's going to be to get an aneuploid blastocyst, if you tell them that only 20% will be normal. So from 10 embryos, only 1 or 2 will be aneuploid. She needs to have 16 mature oocytes. And that's in this age ratio is really difficult. And that's when egg donation enters the scenario. So I think this graphic helps us to explain the patient how pre-implantation genetic test on the aneuploid, on the embryo, to have one aneuploid embryo can help you to get them pregnant. What about the medication, the stimulation protocols? You all have the concerns if you use recombinant LH, if you recombinant FSH, if you use urinary drugs, if you use biosimilars that we have now in Spain from different companies. I'm sure you'll agree from the scientific point of view that the recombinant, so genetic created drugs will maximize the quantity and the quality of the oocytes. Maybe only one oocyte. If you see a lot of papers, but one oocyte in a 41-year-old woman or 42-year-old woman can make a big difference. And just a big summary for you to get all the picture together. I was thinking the other day, how can I summarize for you the goal that we all have for these women to shorten the take-home baby rate in an IVF cycle. Again, if you are very critical in the clinical approach or strategies for every patient, the antagonist, the right drug, preventing cycle cancellation, that's a burden and upsetting the patient a lot. Or the laboratory technology that we are very lucky to have in this country, I'm sure you do have as well, the time-lapse facilities, embryo culture technology, the traceability, and again, all the stability that you need in an IVF laboratory. Again, you can choose by whatever programs and software and through artificial intelligence in embryology, the best embryo to transfer. And again, the patient outcome should be always to have increasing efficacy and trying to decrease the treatment discontinuation. And with the antagonist, I'm sure you agree that the duration of the treatment has less. You need a little injection, no sniffing, you just inject the antagonist from day 6 of the cycle. Again, the protocols, the cycles can start one after the other. If the first cycle is failed, you can do a dual stimulation in the same month or start from day 1 of the period, second cycle, and again, nearly reduced by none the hyperstimulation symptom that was a big concern for all of us. And all this will attribute and shorten the time to live birth. So little cancellation, best tolerability, so little side effects, and a minimum dropout rates. This is very important because the dropout rate, of course, will burden the patients and stop cancelling or producing cycles anymore. And again, the measure, as said to an IVF cycle, well, is to get your patients pregnant, to get a cumulative live birth rate per started cycle. You know very well that the more eggs you have, if you look when you have more than 16 eggs retrieved, you should be able to get over 67% pregnancy rates. So the efficacy is the fresh plus the frozen embryos. If you look at the best recombinant FSH, again, you have to be sure that you use the one that's more pure, the one that has more consistency from batches to batches, and that's, again, the folitropin alpha. When you know that you are injecting, look at this one, if you feel by mass, if you look at the little minus plus 2% of the dose you are giving the patient, but if you feel by BOSA and the other FSH, you have to be very careful, because if you think you're given 60 units, you may be given only 40, or if you think you're giving 93.8 units, you may be given over 120. So it is important to know by the purity of the drug, what are you giving the patients. And again, you know that very well. With the recombinant FSH, now you have more follicles, you have more oocytes, and you have more embryos. So the success rates overall will be higher. Again, you'll have more live birth rate per cycle using little gonadotrophin, the one in purple. You'll see that you use little units to get the same or better result. So that's why recombinant is important as well. And don't forget financially, I don't know in Emirates, but here we have a lot of pressure in the NHS as a public patients to give the minimum drug, the cheaper one, but to get the people pregnant better. So again, from the German registry, over 500,000 IVF cycles, it's demonstrated that they have a better pregnancy rates and less cancelled cycles with recombinant FSH compared to HMG. And again, if you get, remember this paper from Philippe Lehert and Diego Ezcurra from Merck, that you get more oocytes from the recombinant FSH and significant lower dose of the gonadotropin used per cycle. Again, this is a big advantage for the patient and for the clinic. And again, just to finish, remember on the 5 things that I tell you that were important in the last sort of 10 years, changes in technology and drugs, we have the continuous embryo monitoring. In our lab, because we don't have a lot of continuous monitoring incubators, not for all the patients, sometimes we have to freeze the embryos on day 3, but then we put them on the incubator up to day 5 once we thaw them. And the pregnancy rates are much, much higher when they get in the Gary. That's what we're using for our culture system to get pregnancy rates. So really, the message here will be, again, to select your patients properly, to give them all the technology that we have available today. As you've seen, I told you at the beginning, we've changed from the 10% pregnancy rate in the 1980s to overall pregnancy rates over 90% in the year 2020. And I think that technology giving us to our patients the quickest time to get to pregnancy rate. Of course, freezing is important, and vitrification, as I told you, but you need to have a good IVF laboratory. Vitrification, PGTA, freezing embryos only will work in your laboratories if you have good technology and a good embryologist. And I think with this, I finish the presentation. Shukran, and thank you very much.
Thank you very much, Dr. Ramon Aurel. We'll now proceed to have some questions that we received during the presentation. Please. Thank you very much.
Si no me ayudas,
First question, Doctor. How is pre-implantation genetic diagnosis performed?
Okay. The PGTI technology in our laboratory is done by a laser on day 5, so the embryos got into the time-lapse incubator from the egg collection day to day 5, so they're not disturbed, they're in incubator, temperature, oxygen, etc. Day 5, the embryologists, the senior ones, they do a laser biopsy, and then the embryo gets in the vitrification process, and 2 or 3 weeks later, the cell that's sent to the genetic department will give us a diagnosis of a euploid embryo or an euploid embryo. Of course, then when we have the euploid embryo, we'll contact the patients and we'll organize the frozen replacement treatment to transfer the euploid embryo. And again, the aneuploid embryos are, of course, discharged, and we cannot use them anymore.
Another question, doctor?
Thank you.
Does it make sense to use more than 300 units of treatment to stimulate?
It's a very good question. We all had the era about 5-10 years ago when we believed that 450, 500, 600 units of gonadotropins. But again, if you look at the papers that we have recently, the last 2 to 3 years, more than 300 units are not going to give you any benefit. I personally believe that if you have a patient with a very low anti-Mullerian hormone, with a follicular count less than 2, so we have 1 or 2 follicles, even a mild stimulation is very, very good to use for this patient. You don't need to waste money and inject 300 units, when just with 75 or 150, she will respond to these 1 or 2 follicles. And remember, with the stimulation, you will get what the woman has in the ovaries. You cannot create more eggs. So really, that's what you're going to obtain. Thank you.
And the last question, doctor. In which situation elective vitrification is recommended?
Elective vitrification of the embryos, we will, by protocol in our clinic, if you have more than 15 eggs at the egg collection, if you have estradiol level that we monitor every other day over 3,000 picomole the day before the egg collection. But again, common sense for me is more important. And if you have a very slim patient with 12 eggs, estradiol of 4,000 or 2,500, and you are concerned and you have a good vitrification, you're better off doing the trigger with your agonist. Don't risk anything about hyperstimulation, because nowadays in the 21st century, we have no excuse. We cannot have an hyperstimulation patient in our clinics anymore with this new technology. Thank you.
Thank you very much. Thank you very much, Dr. Ramon Aurel.
you.
It was a pleasure to inaugurate the
Thanks to
master
you.
classes of Quirónsalud Hospital Group. Please, doctor, note that if you have more questions, you can put in contact with Dr. Aurel and team in the mail tegnon.fertility@quironsalud.es. And the next Quirónsalud Masterclass is going to be presented next November the 15th by Dr. Kim Casañas, Director of Traumatology Department in Tegnon Medical Center. Thank you very much for your attention, and have a nice evening.
Thank you.